Good day, and welcome to the third and final part of mechanical ventilation, Basics of Invasive Ventilation, number 3. Yay! All right, so I'm so happy you're joining me with this last piece, and I think this is going to help us to cement everything we need to know together. In addition, in your PDF files under ventilation, there's a lovely, lovely textbook that you can review and study mechanical ventilation. And so, to begin, one of the most important things that I would like to remind everyone about, even though I think all of you know this, is in this beautiful slide that I actually borrowed from my colleague Eric Honig, who was a pulmonary critical care physician at Grady until he retired 2 years ago. He just reminds us that up to 25% of our patients will actually experience severe hypotension, life-threatening hypotension after intubation. Now this, of course, can be fatal. And one of the most common reasons that this occurs is that when we intubate, there's a significant shift from negative pressure breathing to positive pressure breathing. If patients have been working hard to breathe prior to that time, they may actually have blown what we call a bleb or ruptured an alveoli, and then when we intubate them and use positive pressure breathing, that positive pressure forces air into the pleural sac, and that of course can cause a tension pneumothorax. Because we've transitioned from negative pressure breathing, which actually increases circulation through the pulmonary vault and into the aorta and into the coronary arteries, once we transfer over to positive pressure breathing, what we can actually see is a compression of the aorta, a compression of the coronary arteries, and a compression of the pulmonary vasculature. So what ends up happening and what can happen is profound cardiac ischemia. That's really related to the role of positive pressure ventilation. In addition to that, what we can also see is almost like a sympathetic sigh of relief. Intubation, ventilation, reduction in our sympathetic firing rates. Now remember, sympathetic discharge increases your respiratory rate, increases your heart rate, promotes vasoconstriction. So once we have rescued our patient from that profound sympathetic drive, it is possible that they can become hypotensive. In addition to that, the transition to positive pressure ventilation, there may be air trapping. And remember, if there's air trapping in the lung, unless we have chosen that as a mechanism, that air trapping in the lung is known as auto-PEEP. And if we haven't chosen that as a style of ventilation, the gas that actually is trapped in the alveoli is dirty, dirty, dirty gas. What that means, CO2 rich and oxygen poor. That's what we call auto-PEEP. Gas trapped in the lung, not allowed to escape. We didn't create it as our form of ventilatory support, and it's CO2 rich gas. So all of these things can be significant post-intubation. So I didn't really talk about intubation in the prior scenario, and I'm very apologetic because I probably should have done that. But I'm saying it now, and also in your PDFs, you'll see a reference to Nicole Kupchak. She's offering 6 short slide sets, 20 minutes each, without any charge, regarding mechanical ventilation, post-intubation, intubation itself, and different strategies, proning, etc. Beautiful series and offered free of charge. Just log into Nicole Kupchak, toggle down to the basics of critical care, all about ventilation. Beautiful, and it will be very synergistic with what we've discussed. Okay, so I want to remind you that when we initiate ventilation, we generally will start with the most familiar and simple mode, and that would be assist control and typically volume control ventilation. So assist control, the mode, and the target is volume. And that volume in general is started or initiated at 6 to 8 cc's per kilogram of predicted body weight. Now I'd like to remind you about predicted body weight, and just a bit later in this series we're actually going to look at a table for predicted body weight. That actually, it isn't actually weight that we are titrating our tidal volume to. We're titrating our tidal volume to how tall you are and what gender you are. Now we use weight because that's a simple strategy, but we're looking at the size of the thoracic cage, whether you're male or female, depending on how tall you are, and making a prediction of the amount of tidal volume that actually can be delivered into the lung without causing overdistension. So we always talk about predicted body weight, but we don't calculate this based on your weight. We also initiate with our FiO2. We always initiate at 100% FiO2. That means 100% of atmospheric pressure, which in Georgia, where we are in Grady, will actually convert to 748 millimeters of mercury oxygen pressure, driving exchange across the alveolus into the blood. So fabulous. And don't forget, whenever you're looking at oxygenation, the easiest thing you can do, not the AA gradient, but the P to F ratio, PaO2 divided by FiO2 in the decimal. And that's always how we're going to communicate about the oxygenation of our patient in response to mechanical ventilation. Next, we talk about minute ventilation. Minute ventilation is frequency, F, respiratory rate, times tidal volume. And normal minute ventilation for a normal adult is 8 to 10 liters per minute. Now let's remember, ventilation, as we discussed with breathing, is about clearance of CO2. Alveolar recruitment and FiO2 are about the uptake of oxygen into the blood. So I always say FiO2 and surface area are about oxygenation, tidal volume, respiratory rate, and by the way, the amount of time you have to exhale is what actually helps us to remove CO2. And then, of course, we think about our old beautiful step sister, positive end expiratory pressure. Positive end expiratory pressure increases the surface area of the lung that's participating in gas exchange. Remember that typically 5 to 8 centimeters of water pressure is typically what is required to keep your alveoli from collapsing, but 5 to 8 centimeters water pressure PEEP does not open previously collapsed alveoli. So we have to be very strategic when we're thinking about these standards in mechanical ventilation. So now I want to remind you that you would always look at your ventilator screen to give you some good information. And so first and foremost, what we're seeing here on our left-hand side is with volume control, assist control ventilation, which basically is the only way we manage patients with assist control. The only way you control a patient is if you paralyze them. So assist control means for every effort made by the patient, the vent will turn on. It's simple. It gives us a predictable, well-controlled tidal volume, and because of rate times tidal volume, it will also give us a predictable minute ventilation. And it's very effective in terms of decreasing the work of your muscles and the work of your diaphragm, which means less blood flow has to be shifted to the diaphragm and more can be delivered to the brain and the heart, which, let's remember, are essential organs, meaning dependent on oxygen and not suffering 1 minute of ischemia well. So we always want to shift blood flow to the heart and the brain, and we can do that by redirecting it from the diaphragm by unloading our respiratory muscles, diaphragm and accessories. The problem, though, with volume control, assist control, is that it can be very uncomfortable for the patient, and it frequently will lead to over-sedation of the patient. Now let's address that right now, because one of the things I really want you to understand, I'm not trying to make you into a respiratory therapist. I don't have the capability to do that. I want you to understand that when a patient is desynchronous with the ventilator, the first concern is this the right form of ventilatory support for the patient? So before sedation is evaluation, assessment, and discussion with your respiratory therapist. Because when patients are uncomfortable with the form of ventilation, if they feel like they are suffocating, if the delivery of gas, either to a targeted pressure or to a targeted volume, if the flow of gas is too slow, they feel like they're suffocating. And this is what causes what we call flow dysynchrony. So if you look on the right-hand column on the top strip, you'll see the gas is delivered, but the patient is pulling with negative inspiratory force. And you see that little dip there. That little dip on that first screen on the right-hand side, you're seeing that gradient of change in flow. That the patient is trying to breathe faster than the gas is being delivered. It makes them feel like they're suffocating. It makes them feel like they're drowning, that they have a plastic bag over their head. And if they're already delirious, oh my God, this is terrible. So before you increase sedation, assess the form of ventilation and communicate to your respiratory therapist, and then communicate together to your physician team. So very important to appreciate if the patient is breathing hard against the ventilator, they're going to become more and more agitated. They are probably going to start to suffer respiratory alkalosis, and the pressures in the airway are going to go up very, very high. Now, as airway pressures go up, that promotes barotrauma. And barotrauma is basically overdistension and destruction of the very, very beautiful and fragile alveolar wall. So we want to be aware of that. And the other problem here is that, honestly, it's sort of like promoting a lazy diaphragm. So let's just say for 1 year, you went to the gym, you started with a 5-pound lift, and now you're at a 150-pound lift, and you've got some big old beautiful muscles. And then you get sick, and you don't exercise for 4 months. Now your muscles have atrophied, and you have to start all over again. This is what can happen to patients who are on assist-controlled ventilation because they have a diaphragmatic atrophy because they're not working their muscle. So the key to this is a very fine balance between overwork of the diaphragm, and underwork of the diaphragm. And we're always going to be aware of this when we're supporting patients on ventilation. Now, generally, we don't worry too much about this if we think you're just going to be intubated for a day, 2 days, 3 days. After 3 days, we have to start being concerned about diaphragmatic atrophy. Okay, then the other mode, which of course is SIMV, and just as a reminder, SIMV means you always have a mandatory rate. That's going to be delivered on a time cycle. And in between that, you have spontaneous breaths that are supported with a flow of gas to either a targeted pressure or a targeted volume. So what's the difference between the mandatory breath and the supported breath? The degree of the target. So a volume supported breath might be 350 mLs of volume, but I'm so sorry I said that incorrectly, so please let me correct. So my mandatory breath, that's a volume target, might have a volume target of 350 mLs tidal volume. My volume supported breath will have a much lower target of volume. My pressure controlled breath has a high target of pressure, up to about 40 centimeters of water pressure, but my pressure supported breath has a lower pressure target. So they are really absolutely similar. They're all related to the amount of flow that the patient gets with the breath, the gas flow, the rate of speed, and the target. So SIMV, as you see here, you have your mandatory breath, then you have your supported breath. You have a mandatory breath, and you have a supported breath. Okay? We do not actually intubate patients and put them on SIMV and allow them to take a supported breath without having pressure support. In general, at Grady, we don't use volume support, although we have the capability. In general, we use pressure support for those spontaneous breaths that are not in the cycle of time of the mandatory breath. So I've set your rate at 10. You're going to get 10 mandatory breaths per minute. But in between, if the patient initiates effort, he will then get a supported breath. What's the difference? Mandatory breath. Flow is diverted to the patient to a target, either volume or pressure. Spontaneous breath. Flow is diverted to the patient to a much lower target. Now this is why your therapist will say, once you get to a pressure support of 15 to 20, you're giving your patient a pressure targeted breath. This isn't really SIMV anymore. It's basically assist control ventilation. So all of us know that you can give something a term, but you have to understand that term to make sure that we're doing the right thing. Okay, so we know that there's not much evidence for improved comfort or avoidance of diaphragmatic atrophy with SIMV, but I would like to just remind you in general, if I was making a strict line, pulmonary critical care physicians choose, in general, assist control ventilation, and trauma surgeons and surgeons choose SIMV. So we see a difference between our different professions, our different professional groupings within our practice. But honestly, there is very little evidence for SIMV. I'm cool. Let's do SIMV. You set a rate of 22, the patient's breathing 22. It can say SIMV, but it's not SIMV because the patient's not breathing over the vent, and every breath he gets is a mandatory breath. If I set my rate at 10 but give my patient pressure support at 25, I can say SIMV, but it's not really SIMV. It's a pressure control ventilation. So very important to remember, the Tidal is only relative to the dynamics of the settings that we've made on our ventilator. Okay, so this is pure pressure support ventilation, meaning no mandatory breaths. That's all that means. No mandatory breaths. It's just the patient initiates a breath, we flow gas into the target of pressure. So very, very important. We do know that this actually does improve patients' comfort as we are training them to come off the ventilator. It may or may not significantly improve diaphragmatic work, but from my belief, I would say, remember I talked about 5 pounds to 150, sick for 3 months, I'm going to start again with 5 pounds. So I am somewhat training my diaphragm to become stronger. It's going to be much more comfortable for our patients, and we have a very high inspiratory flow. So if you take a look at the flow dynamic here, which is in the middle, the flow goes in, woo, and then it decelerates, woo, and then it decelerates, woo, to the pressure target, and then it decelerates. So that means that patient gets his breath pretty fast, and this is so fabulous. It's such a fabulous way to wean our patients. So now let's just take a look at all of this in comparison. So first we're going to start with volume assist control, and you're looking at a pressure time waveform. Our patient starts his breath at a PEEP of 5, so he's not at 0. So hopefully some part of his breath will not be required to open the alveoli because we've kept them open. That means the volume gets delivered more efficiently because the alveoli are relatively open. And what you're seeing here is the gas flows in and then it flows out, and then it flows in and then it flows out. First breath, mandatory. Second breath, mandatory. Third breath, mandatory. Fourth breath, patient triggered. Okay, now down to pressure support ventilation. Again, we're looking at pressure over time, and you can see that every single breath here was initiated by the patient. He had a negative inspiratory force, or he had a redirection of flow, either one. It's a flow cycled or a force cycled. And the patient has negative inspiratory force. The flow of gas goes into the ET tube and into the lung, achieving a pressure gradient. Beautiful, a pressure target. And again, remember, the difference between pressure support ventilation and pressure control ventilation is merely the pressure target. One is low, the other is higher. That's all, folks. Beep, 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 beep. Okay, SIMV without pressure support. Patient's getting his mandatory breath. He initiates a small breath, and the flow, actually he's just breathing from flow by, but flow doesn't get diverted to him. So he's breathing on his own breath. So you can see mandatory breath, Spontaneous without pressure support, spontaneous without pressure support, mandatory breath timed to the patient's own effort. That's the beauty of SIMV, is the attempt that smart ventilator is actually going to attempt to deliver the mandatory breath in conjunction with the spontaneous effort. And then below that, SIMV with pressure support, which is the #1 way you will see SIMV being used at our hospital, is that the patient made an effort and he gets a breath. He made an effort and he gets a supported breath. Made an effort and a supported breath. And he made another effort and he got a mandatory breath. So again, on the bottom graphic, effort, mandatory breath. Effort, supported breath. Effort, supported breath. Effort, mandatory breath. Fabulous. And this also helps us to look at the airway pressure and flow tracing. So what you're seeing here is a spontaneous breather with no support. So he has to generate a negative inspiratory force below atmosphere, which we call 0. Below, and gas moves in and goes above. Below, and gas moves in and goes above. Below, and gas moves in and goes above. All varying around that 0 pressure line. But a lot of his breathing is wasted delivering gas down the bronchioles all the way to the respiratory bronchioles and the alveoli. So much of your breath is wasted trying to get gas into your alveoli. That's why we apply CPAP. Remember what CPAP is? Continuous positive airway pressure, so that when you make an effort, most of that gas will be delivered to the open alveoli instead of trying to overcome all that resistance, making it less hard for you to work to breathe. So we love CPAP. Remember, CPAP is continuous positive airway pressure, and it's applied primarily or absolutely in its absolute framework to a patient who is spontaneously breathing. Okay, so now we're going to take a look at the 840 ventilator screen. And that 840 ventilator screen, by the way, is the majority of ventilators that you're going to see in the ICUs here at Grady. We do have some 960s. Those are the newer ventilators. They're beautiful. Conceptually, the basic components are going to be very similar, but the layout is going to be different and the capability of the ventilator is different. 840 is somewhat smart. 960 is really smart. And the next rendition of ventilators will be almost to an AI level. So this is really important. Our ventilators keep getting smarter, and that means that the ventilator is programmed to actually appreciate the patient's dynamics, the compliance of the lung, the resistance, the recoil. The ventilator is becoming smarter in terms of actually being able to shift methodologies related to patients' lung compliance. Isn't that a gorgeous thing? It's amazing, and it's going to happen in my lifetime. So you know it's going to happen multiple times in your lifetime. Now, if we take a look at the far upper left-hand letter, you'll see here that that letter says S. S is red. S means spontaneous. A is green, and that means assist. And C is control, and that's going to be yellow. So right now you can see our patient is initiating spontaneous breaths. Next to that will be the peak pressure. That means the highest pressure achieved when gas is being forced into the patient's lung. Peak pressure is resistance plus compliance. Okay? Next to that is the mean airway pressure. And the mean airway pressure is the derivation of the peak pressure and the end pressure over time, looking at the constant state of pressure in the airways. After that is PEEP, positive end expiratory pressure. Following that is the proportional ratio, not the time, the proportional ratio of inspiration to exhalation. After that is the frequency of breathing. Following that is the exhale tidal volume, and at the end is your minute ventilation. So that's a really lovely methodology of looking at our patients. So now let's look over to the right, and what you can actually see here, such an important perspective, are the settings. So below the graphic, so looking at this patient, this is a different patient than the one on the left, this is a different patient. You can see his breath types, his measured outputs that are all across the top of the screen. Then below that, the graphics of the pressure in the circuit and the volume, depending on where you've set your scalars or your graphs. But right now, it's on the circuit pressure, and on this one, on the right-hand side, is the volume. On the left-hand side, it's pressure graphic and flow, which is that V over L. That's the flow per minute. Okay. Now we look down at the settings, and in the settings you see patient is set at SIMV, 12 breaths per minute, but when we go up to the top we see he's breathing 28, so he is indeed breathing spontaneously. He's on a VC+, which we have discussed a little about. That's a volume with a pressure limit, so the flow actually changes based on the patient's lung compliance and based on their eye time. Next to that, you see pressure support, which is 10, yay. And then we look at our flow rate. That's the V subset E, or I'm sorry, that's not the flow rate. So sorry, I'm far from the screen, so I'm spitballing because I thought that's what it was. But it's actually the derivation of flow redirection that turns on the gas flow to the patient for pressure support. And then after that, FiO2, below that is PEEP. And then next to that is the percent of your cycle that is spent in inhaled flow, the amount of flow that's during inspiration related to the rest of the flow, the majority of flow that occurs right away. Okay, so I want to look back up at the graphic, and I want you to see first breath is red, that means it's spontaneous. Second breath is green, that means it's mandatory. Next breath is red, that's spontaneous. Next breath is green, that's mandatory, and so on until you see 2 spontaneous breaths that occur and then another mandatory. So this is an example of how smart that ventilator is, readjusting its cycle time to every spontaneous breath. Just very much like a pacemaker. A pacemaker senses that the patient has his own beat. It withholds the delivery of the mandatory spike, just like the mandatory breath here, until the cycle time has been reached. It's quite fabulous and really lovely when we look at that ventilator screen. So again, just to remind ourselves, we get these measurements of peak pressure, mean pressure, PEEP, the components of inspiration to expiration, not the time in seconds, that's not what that is, and then the total respiratory rate, the exhale tidal volume, and the minute ventilation. And we can see how lovely that is. And then we look again at the settings, which are below the waveforms. So those setting keys are soft keys, and what we see up at the top, that's just a display. I can't change anything by pressing peak pressure or mean pressure up at the top, but I can change everything when I press down on the bottom. Now, nobody is allowed to touch that ventilator except the respiratory therapist. Now, we don't control our physicians, but we do control ourselves. So with permission, your respiratory therapist may say, okay, you need to increase that FiO2. I'm outside the room, I'm watching what you're doing because you're dressed and you're in the room and you're in a COVID-19 room. You might be approved to increase oxygen, but that's really going to be the only thing that you're going to do. And you would never, ever do that without the approval and the oversight of a respiratory therapist outside the room. You do not make vent changes. You can look at different graphics, but you cannot change the ventilator settings. Are we good? I hope we're clear. Okay, so now we think about our initiation mechanical ventilation. So the first thing that we discuss is mode. Are we going to support the patient fully? That will be assist control, or SIMV if the rate is 12 or higher. That means all the work of breathing is done by the ventilator. Or we might do partial ventilatory support, which means there's going to be a hybrid mix between the mandatory breathing and the patient's spontaneous breathing. So if the rate on your SIMV is less than 10 per minute, you're doing partial support, and in general, you're going to give pressure support ventilation for those spontaneous breaths. And BiPAP is also a form of partial ventilator support. We can do bilevel through an ET tube, or we do BiPAP non-invasively. Okay. Another initial setting is the respiratory rate, and typically we're going to start a patient at 8 to 12 breaths per minute because that's closely in contact with what the normal rate is, which is 12 to 18. but it's going to allow us some time to look at the dynamics of how the patient is going to respond to the ventilator. Now, your respiratory rate is always chosen in conjunction with that tidal volume in order to drive a normal minute ventilation. Now, normal minute ventilation, normal human beings, is 8 to 10 liters a minute. We might use a lower minute ventilation or a higher minute ventilation, depending on what the patient has been doing prior to intubation. And one cautionary tale here is, if my patient is compensating for metabolic acidosis, I would like to replicate as best as possible what he was doing prior to intubation. So if he was breathing 25 times a minute before intubation, I might start him at 20 to 22 breaths per minute until I'm able to assess what else can be done. I don't want to control him pharmacologically with a low rate if what he was doing was compensating for metabolic acidosis. Now, we are going to look at ventilation separately, and that's actually going to be the ability to mobilize your CO2. So we're going to look at our initial settings. We're going to look at what our PaCO2 is. If it's greater than 45, we either are going to determine that we want that CO2 down, or based on the requirements of the patient's lung and his lung compliance, etc., we might say we're going to allow hypercapnia. That's known as permissive hypercapnia. And if the CO2 is less than 35, if what we're trying to achieve is reducing diaphragmatic and accessory muscle work, but reproducing ventilatory capability to compensate for metabolic acidosis until we can fit it, we're going to be okay. If your patient doesn't have any kind of a metabolic problem and you're breathing him this fast and his CO2 is down, you have to have a reason. One reason might be we keep CO2s between 30 and 35. If you have increased intracranial pressure because the CO2 goes up, you're going to vasodilate. And so cerebrally vasodilate. So it's very important to understand the context, and I'm giving you simple strategies of how to look at how to start mechanical ventilation. But those strategies that I'm giving you are in the context of a normal lung and a normal patient, which, by the way, if they were that normal, why are they getting intubated? Who knows? Okay. Tidal volume and frequency. So VE, remember, is minute ventilation. And that's tidal volume times frequency. So you and I are breathing around 5 to 6 liters normally. 7 to 8 to 9 is about baseline for ICU patients. But patients who have a high degree of metabolic acidosis are going to need a higher minute ventilation to maintain compensation for metabolic acidosis. So when you come into a room and you have a patient who has a base deficit of -10 and a pH of 7.16, your expectation would be that their minute ventilation might be 12, 13, 14, or 15, meaning frequency and tidal volume have been adjusted to maintain compensation for the metabolic acidosis. Now, if their pH was 7.1, you didn't achieve that. But if their pH is 7.32, you probably have achieved as much as you can. Always important to remember that tidal volume and frequency are intimate together. They're like the most wonderful married couple you ever saw, like Dick Van Dyke and Mary Tyler Moore, if you happen to know who that is. They have a wonderful relationship, and that's what tidal volume and frequency have. So we're always going to attempt to have a lower tidal volume related to predicted body weight, but maybe a little bit higher respiratory rate in order to maintain a good minute ventilation. But I want you always, always, always to remember that if the problem is getting rid of CO2, another concept is to look at how much time is spent in E, right? So remember we looked up at the top of the screen at I:E. That's the proportional ratio. You always want, when you're doing basic standard ventilation, you always want your E time to be longer than your I time. If what I'm trying to do is recruit your alveoli, your I time will be longer than your E time. But if E time decreases, CO2 retention is going to go up. Now, in a normal breath, we'd like to allow for about 4 seconds for our patient to exhale. So that's really important. Remember, that just depends on how fast you're breathing, but the proportional ratio between inspiration to exhalation typically is 1 to 2 or 1 to 3, meaning 1 part of the cycle is inspiration, 2 parts of the cycle are exhalation. And depending on the rate will determine how much time you have for exhalation. Now, over on the right-hand side, you see this little formula, and this little formula is the formula for predicted body weight. So what I want you to look at is that we're talking about the volume plus a standard factor. That's standard, well, really it's volume plus standard factor times height minus 60. Nowhere in there do you see weight. So I just want to refer you to the idea that predicted body weight is a methodology for protecting your functional lung. So I want to make sure you appreciate and understand what I'm saying. Using predicted body weight is a lung protective mechanism, not a lung recruitment mechanism. It protects your lung, but it doesn't recruit it. Now, this is absolutely essential for any patient with ARDS, and we want to remind ourselves, we've had a discussion about this before, and we'll discuss it again, that in COVID-19 we have 2 types of patients. First group of patient, known as phenotype L, has a very compliant lung, but he has really a lot of destruction of his red blood cells and not having an adequate ventilation to perfusion relationship. But he's got compliant lungs. But that progress goes from type L, phenotype L, to phenotype H. Phenotype H is a more traditional ARDS. ARDS lungs, by the way, the key frame of the ARDS lung is non-compliant. That means non-distendable. So we're going to protect the functional lung, but we're also going to think about methodologies to distend the dysfunctional lung, and so that we can distribute tidal volume across the whole lung surface instead of just a tiny little lung surface. So in today's world, in general, we use lung protective strategies if we're using volume ventilation. And when we put patients on pressure control ventilation, understanding that we are protecting the lung. So predicted body weight, tidal volume with volume control ventilation is a lung protective mechanism. Pressure control ventilation is always a lung protective mechanism as long as we've set our pressure targets appropriately. Now, the definition for true lung protective ventilation with volume means less than 7 mLs per kg predicted body weight. And when we trap the air in the lung and look at the distribution of gas across the lung, it means that we're going to titrate our tidal volume until we get a plateau pressure less than 30. Now, we've talked a lot about plateau pressure, and now it's time for us to put that into play. We're going to allow adequate expiratory time because we need bad gas to come out. We're going to avoid what we call auto or intrinsic PEEP, meaning gas trapped in the alveoli and it's oxygen, poor gas, CO2-rich gas. And typically we like to target the SpO2 to the mid-90s. But in today's world, we also say above 88 is going to be okay. We think that's really okay. So an 88% SAT is going to be acceptable in general. Don't flip out so much when your patient's 91 or 90%, as long as you feel that you've optimized ventilatory support and you're following other kinds of keystrokes here, right? We don't need to have 100% SpO2 for the majority of our patients. It's just not necessary. Now, I want to remind us again about tidal volume. The tidal volume that's actually delivered into the patient lung is usually lower than the ventilator-delivered volume. That's why we look at the exhaled tidal volume. And when you see V subset T up on the top, where it's actually the measure versus what you've set, it's not going to be the same number in general. It's always going to be a little lower. That's because there's a little leak from the ventilator circuit, a little leak with your ET tube and maybe through the cuff, and just a compressible circuit volume loss. So you might have dialed 350 and the patient is getting 310 or 330 or 335 because you have some volume loss in the delivery of the circuit. Now, in general, newer ventilators, and as they become smarter and smarter and smarter, they compensate for that volume, that compressible volume that's in the tubing and in the circuitry. Okay. So again, I'm going to remind you, tidal volume is in a range of 6 to 12 mLs per kilogram for predicted body weight or ideal body weight. But let me just tell you, I don't ever, really ever anymore see anybody with a tidal volume of greater than 10 mLs per kg, and typically not that. We usually start right around 8 mLs per kg. So let's just think about where that comes from. So first and foremost, all you have to do is Google ARDS, all caps, and then 3 small letters, one word, net, ARDSnet. On the ARDSnet, when you go to the ARDS network, there is a huge abundance menu of choice. And here, what I'm showing you is getting to what we call the predicted body weight calculator. So every respiratory therapist has this on their phone. Most of them have it in their pocket. Many of them already even have it memorized. But here's what it looks like. Okay? So first and foremost, that we're going to use tidal volume to maintain a plateau pressure of less than 30. And in most cases, we want it less than 25. So you can see the way we're going to do that is by reducing tidal volume. We're protecting your lung. And we're going to make decisions about your predicted body weight from a table. Now this table's not that easy for you to see, but it's totally available. ARDSnet space PBW, predicted body weight. You'll get that table. And that table will say for this height, if you're a female, you're going to give this much tidal volume if you're trying to give 6 cc's or 7 cc's. Same thing for a male. So remember, it has nothing to do with your weight. It has to do with your gender and your height. And by the way, you don't even have to calculate it. All you have to do is look at it on your smartphone. ARDSnet, all one word, PBW. This will come up, the predicted body weight calculator. It's phenomenal. It's such an easy thing to look at and to do and to make sure we're doing the right thing. And the reason we do this is because if we were looking categorically, and what I was saying is the alveoli on the left was relatively dysfunctional, what I don't want to do is overdistend my prior functional alveoli, because as I overdistend them, I'm going to create a stress and stretch barotrauma injury. So what was once your good lung will now be your bad lung because I've overstretched it. Just like if I have a beautiful pair of ski pants and I gained 100 pounds and I still wore those pants and then I lost 100 pounds, those pants would be overdistended. They'd be overstretched. They weren't recoiling and therefore not functional anymore. So we always want to remember that when we're talking about ventilation. So again, what we use here to help us understand this is, first and foremost, your peak pressure. Peak pressure, when I deliver the gas into the patient, what is the pressure that is generated? And that response is actually the lung surface plus the volume. Okay? The surface plus the volume. The smaller the surface at the same volume will give me a higher pressure. The bigger the surface at the same volume will give me a low pressure. Pretty straightforward. From that, we remind ourselves about plateau. And plateau pressure, remember, is when I press an inspiratory hold button. You're not going to do that. Your therapist does it. Inspiratory hold button. The ventilator at peak flow closes the exhalation valve so the patient can't exhale. And that gas is delivered across the lung surface. And it's for a very short period of time. But the ventilator is so smart, it freezes the graphic and it displays the plateau pressure. Okay? In addition to that is your mean pressure, and that's the average between the peak and the end, also correlated to the amount of time spent in inspiration and exhalation. And then, of course, positive end expiratory pressure, which is the gas flow that continuously circulates to maintain alveolar opening. And remember, in today's world, typically, we use 8 centimeters of positive end expiratory pressure to maintain your lung opening. And if we're trying to open previously collapsed, we'll go to 12, 14, 16, 18, 20, and then we will most likely, not always, transfer over to another form of ventilatory support that actually recruits, meaning opens, your alveoli. All right, very good. So, first and foremost, troubleshooting your vent. If peak pressures are going up, that means that there's either resistance or loss of compliance or a combination of both. If peak pressures are going up, we're going to look at the patient, obviously. We're going to make sure he's not biting, coughing, spitting, trying to get his tube out. But then we're going to think about the plateau pressure, because that will tell us about the compliance of the lung without the resistance, meaning I'm not pushing gas in, I'm just trapping it there. If the peak pressures are high and plateau pressures are low, there's a problem between the ET tube and the distal airways. If both peak pressure and plateau pressure are high, you've got a lung compliance issue. You need to open alveoli, you need to relieve a tension pneumothorax, you need to relieve a hemothorax. You have to remind yourself that plateau pressure is really the best measure that we have of looking at alveolar compliance. Okay, so this is a beautiful troubleshooting algorithm. Again, I'm going to correlate this back to Dr. Honig. I made a few minor adjustments, but basically troubleshooting the algorithm. Your patient is having a struggle breathing, and his peak inspiratory pressure alarm is going off. You're going to look at that patient. You're going to see what he's doing, okay? So if your peak inspiratory pressure is increased, the next thing I'm going to think about after I've looked at the patient, made sure he's not biting, spitting, coughing, gagging, there's not a lot of junk in the ET tube in the circuit. If that peak pressure is increased, I'm going to move to plateau pressure. If that plateau pressure gets measured, right, but the plateau pressure is low, then the problem is resistance, aspiration, bronchospasm, secretions, an obstructed ET tube, a mucus plug. Those are resistance issues. If plateau pressure is increased, you've lost your compliance. You lose compliance with pulmonary edema, atelectasis, pneumonia, ARDS, intrinsic PEEP, abdominal distension, and the diaphragmatic floor is up into the thorax, and ventilator dysynchrony. So the patient is fighting the ventilator. And remember, don't just give sedation. Try to figure out what the problem is. Okay? So now I'm going to step back up to the peak inspiratory pressure. If your peak inspiratory pressure is measured and then you measure a plateau and the plateau is down, you have an air leak. And your patient may actually be mobilizing gas into a pneumothorax at the early stage. Remember, at a later stage, that pneumothorax will actually cause a loss of your compliance. If your plateau pressure is fine, but your peak inspiratory pressure is up, something else could be going on. So we always want to be aware of these perspectives. So your plateau pressure is unchanged, but your peak pressure is up. Very important. Okay, so I want to remind you about your vent settings. Vent settings to improve oxygenation are about surface area of the lung, and the easiest way to increase the lung surface area is with PEEP, with increasing your mean airway pressure, with PEEP, opening your lung, and FiO2. And in general, remember, we're going to adjust these in a ladder or in tandem, because what we're trying to do is to actually open your alveoli and return your oxygenation to a better level so there's less cardiac stress, trying to accommodate for better oxygen delivery. If I'm trying to improve CO2 clearance, I'm going to consider the minute ventilation. So I'm going to look at respiratory rate and tidal volume, and I'm going to adjust your minute ventilation. Never going to have a respiratory rate greater than 35 times a minute. That's really high, and that's going to cause other problems. We want to be less than 10 mLs per kilo, and we're going to continue to reduce that because we don't want to cause volume trauma or barotrauma. So remember, also really, really, really important is your exhale time. At some point, we may make all the vent settings we can, and we still are not able to remove CO2, at which point we'll say, we've tried everything. We're just going to allow our patient to have a higher CO2. We're probably not going to want him to have a low pH, and we might use other methodologies to neutralize his metabolic acid while we're accepting his respiratory acid. Okay, so inspiration to expiration relationships, remember, that's one of the things that allows us to exhale. And if we've chosen alveolar recruitment, that means that we're inspiring for longer and exhaling for less time. That might mean we have to accept permissive hypercapnia. Always reminding ourselves that what we want to do is to protect our lung. So if peak inspiratory pressure is going up and up and up and up because there's a lot of resistance, we're going to reduce the volume. And as we reduce the volume, because we're going to make the volume smaller to fit into that smaller lung, we are going to actually have an increase in CO2 because we're not mobilizing that gas out. Again, permissive hypercapnia. So always very important when we think about this, an improvement of ventilation. So just as a reminder, adjustments are made based on ABG and the mechanics of the lung. So for CO2, remember that CO2 is inverse with minute ventilation. As minute ventilation goes up, you expect CO2 to go down. Adjust tidal volume or frequency, or both, depending on the patient's pathophysiology. It will not correct hyperventilation due to a patient's mass balance or his metabolic acidosis. We won't be able to correct that. Okay, oxygenation, FiO2, PEEP, and mean airway pressure strategies. Mean airway pressure strategies are things like, beyond the class that we're in, pressure control inverse ratio ventilation, which prolongs I time and shortens Z time, right? And gives us more time to recruit the alveoli. Or airway pressure release ventilation, which is an extraordinarily high pressure over a period of time on top of which the patient breathes spontaneously with a very short exhalation time or a reduction time that sucks the CO2 out of the lung. It's a beautiful thing. So we always think about peak pressure, time of inspiration, and PEEP as that all relates together for oxygenation. Time for inspiration, longer, shorter. Longer time means more alveolar recruitment, shorter time, less alveolar recruitment. PEEP peak, which is a measurement of the lung resistance and compliance, and PEEP plateau, and then reminding ourselves that when we see a plateau pressure, we actually assume that you have to be just above that plateau pressure or just above the mean pressure to actually open the lung. Okay, so when we're troubleshooting the vent, we have common problems. High peak pressures, patients who have very distendable lungs but are not elastic, so they don't recoil. Dysynchrony with the ventilator, and significant and profound loss of compliance that we see in ARDS. So just remember, peak pressures increasing, always look first at the patient, see what he's doing. Is there secretion in the tube? Is there fluid in the circuit? Is the patient biting, tonguing, fighting, coughing? And then we consider checking the plateau pressure. If the plateau pressure and the peak pressure are high, this is loss of lung compliance. If the peak pressure is high but the plateau pressure is normal to low, you have an obstruction, a mucus plug. The ET tube has migrated. Very important. This is so incredibly easily a signpost to what your problems are. It's not the full diagnosis, but it's definitely a signpost to the true problem. So that's really good to know. Now, if you have a patient who has a history of COPD asthma, who is worsening his oxygen and increasing his CO2 retention, the differential will actually be about, does your patient have enough time to exhale? Because if he doesn't have enough time to exhale, he's going to stack breaths before he's completed exhalation. Now, if you're me, you breathe in like this and out like this. In like this. But as a COPD patient, I breathe in like this because I can move a lot of volume in, and I exhale out like this. So if I increase his respiratory rate, it's oh, I can't even do that for long because it makes me short of breath. But what you're actually seeing me show you is that I'm not exhaling my gas, and that gas is CO2 rich. So that leads to what we call auto-PEEP, or intrinsic trapping of gas, also known as breath stacking. And guess how I know that? Because I can look at my flow graphic and see gas flows in and then out, and before the next breath occurs, that flow line should come back to zero. But with a COPD patient, it doesn't unless you have an extraordinarily long time for exhalation. So you need to be aware. Decrease their respiratory rate and flow the gas to the patient faster. If their lung is compliant, you can shove that gas in really fast, 100 miles an hour. not really, but you can go to a flow rate that's 60 to 80 to 90 liters per minute. Faster, 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 faster. So inspiration is quick and exhalation takes much more time. So you would go to an I to E of 1 to 5, right? Not 1 to 2, 1 to 5, meaning 5 components of the cycle are spent in exhalation, only 1 component in inhalation. The thing is, you can't do that if the patient's lung's not compliant. Because if the lung's not compliant and you try to force that gas into them too fast, the pressure measure is going to go way the heck up and you're probably going to cause a significant injury. So first you have to know that the lung is compliant and then you can flow the gas faster. Okay, that's pretty cool, right? That adjusts the I to E ratio. We can actually manually adjust the I to E ratio, not us as nurses and not really as physicians, but respiratory therapists can adjust the I to E ratio and really create a much better perspective. Now, we can also decrease the tidal volume, but if we decrease the tidal volume, we're going to need to increase the sedation because the patient is going to feel air hungry. All right. If we note that our patient is agitated and is dysynchronous with the ventilator, lots of times this is because they are air hungry. So I want you to adjust that first or to think of that first. Increase tidal volume, increase the flow rate, adjust the I to E, and then ultimately increase sedation. Increasing sedation, you might need to do it to keep the patient safe while you're figuring out what the problem is. I understand that. I'm a nurse. I'm at the bedside. I understand it. We don't want our patients uncomfortable and we don't want them to extubate. But the majority of time that patients are agitated and dysynchronous with the vent, it's because the vent settings don't actually support the patient. So one of the beautiful tributes here is if I'm on assist control, volume control, I can shift to VC+, and I can't do that, my therapist will do it. But the therapist can shift to VC+, which means that you have an alternating flow dependent on how fast that flow goes and what that pressure generation is. The gas will flow faster or slower. This is also known, VC+ on our ventilator is also known as pressure regulated volume control. So if you're looking it up in a textbook or you want to know more about it, pressure regulated volume control. And very, very frequently, I'm so lucky, I'm so honored and lucky to be at Grady and to work with some of the best respiratory therapists in the world, where I can call the therapist and say, I have so much concern, my patient is really dysynchronous. They come in the room, they make some simple adjustments, they look at what happens, they say, yes, that worked, or no, that didn't work. But I always want them first to have the opportunity to make an adjustment, and then I'm going to consider sedation. So I rely personally very, very heavily on my respiratory therapy colleagues, and I am again going to remind you that you have some incredible, incredible therapists that work with you in the ICU and in the emergency department that help us to actually make the ventilator fit the patient, not the reverse. There are times when we have to make the patient fit the ventilator, but they are few and far between. So really think about relying heavily on your respiratory therapist. I want you to recognize the problem, and I want you to be able to communicate effectively with your therapist and with your physician colleagues. I'm not expecting you to become a respiratory therapist, although that would be really great. You could follow in the footsteps of the great Sandy Jacobs, nurse and therapist. But I am expecting you to have a basic understanding and to utilize this information appropriately and accurately. If you have concerns that your patient has ARDS, of course, we're going to look at the physical assessment. We're going to look at the chest x-ray, looking for patchy diffuse infiltrates, looking at a P to F ratio, typically if it's less than 200, if you're on 40% or greater FiO2, and 5 or greater PEEP, and you have a PF ratio less than 200, it's likely to be ARDS. And that's when we start that ARDS-NET protocol. The very first thing we do is we're going to protect your lung. We are going to protect your lung. We're going to reduce your tidal volume. As we reduce your tidal volume, you are now going to start to retain CO2. And now all my goal, once I've reduced that tidal volume, my whole goal is I want the lung to be open. So I'm going to increase PEEP. I'm going to increase PEEP. I'm going to increase PEEP. I don't increase the FiO2. Really, I like to increase the PEEP. Now I might do that in tandem, 2 steps up in PEEP and then a step up in FiO2, 2 steps up in PEEP and then a step up in FiO2. The problem is that all the while you're stepping up a ladder of PEEP, you're actually trying to get to this ultimate point where you can open the alveoli. So that's a very important situation. It's very important for us to understand it, and it's very important to communicate with your respiratory therapist. Now, in the meantime, I might need that patient to be synchronous with the ventilator because he's putting himself at risk, because he's struggling and he's dysynchronous, he's not getting tidal volume, he's not getting oxygenated, he's not removing CO2. So I might have to consider an increase in sedation, but only for a short time. And that isn't a long-term strategy, everyone. It's not a long-term strategy. Okay, so some of our alarm settings, high minute ventilation just means if my patient's becoming tachypnic, he's breathing faster and faster and faster, or the ventilator is self-triggering, we're going to have a high minute ventilation. We're going to get an alarm for that. We have to investigate why there's a high minute ventilation. Is my patient agitated? Is he in metabolic acidosis and attempting to move more volume in order to compensate? All those things are important. That often, high minute ventilation is almost always in conjunction with a high respiratory rate alarm. So again, remember that patient may be very agitated, he's breathing really fast, he's in respiratory distress, he can't get the gas fast enough, he thinks he's suffocating, or he's trying to compensate for metabolic acidosis. So that's very important. The other thing is that the vent may be triggering very simply at the slightest request. In fact, the patient might be hiccuping and the vent's turning on. So we always want to look at that relationship as well. Is the target trigger, which actually turns on the vent breath, is that set high enough for this patient, or is it too low, meaning it's really ultra sensitive instead of being a little bit less sensitive? Okay, low exhale tidal volume, that's really, really, really important. If my patient isn't exhaling his tidal volume, it's going somewhere. It might be an air leak, it could be a cuff leak, it could be that the circuit is disconnected, or he might actually be leaking the volume into the pleural sac. So pay attention. Low exhale tidal volume, look at your patient. Are they synchronously expanding? That's the first thing. What's their SAT? What's their heart rate? What's their blood pressure? Because you're trying to investigate, is it possible at this moment, low exhale tidal volume, high peak inspiratory pressure? That is probably a pneumothorax. Low exhale tidal volume, low peak inspiratory pressure, that's probably a circuit disconnect or a tube leak. So look at low exhaled, look exhale tidal volume, that's the alarm that's going off. Immediately look at your peak pressure. Peak pressure's up, low exhale tidal volume alarm is ringing. Your patient probably has a pneumothorax. Okay. Low exhaled minute ventilation. Again, the same basic issue, that the low exhaled minute ventilation is the low exhale tidal volume. But it means that you've had a low exhale tidal volume for a minute. Oh my God. That means you might have been disconnected for a minute. This is not okay. You've got to pay attention to those alarms and know what they mean. Low exhale tidal volume yields low exhaled minute ventilation, meaning you didn't breathe enough volume and you didn't do it for a whole minute. So now your minute ventilation is down. Okay. High inspiratory pressure alarm, I think we've talked a lot about that. Typically, we set that alarm on an assist control volume ventilation. We set that alarm about 10 centimeters above what your peak pressure is. So if your peak pressure is 35, I might set that high inspiratory alarm at 45 or 50. So always want to remind ourselves lots of things affect how the gas flows into the lung and what can obstruct it. Things like water in the circuit, biting, kinking, tonguing, coughing, secretions in the airway, bronchospasms, attention pneumothorax. Remember, if I have low exhale tidal volume and a high peak inspiratory pressure, that's almost always a pneumothorax. And that's, of course, very, very concerning. What's the best diagnosis? You can't stop the alarm. You take the patient off the vent, you back them, and you back them first. It's easy. The next breath is harder, and the third breath is harder even then. You have a pneumothorax. So now you've got to move gentle volumes. because you don't want to make the pneumothorax worse. Any decrease in lung compliance, any increase in airway resistance, and of course if the patient is coughing. So look at the patient. First, evaluate the synchrony of lung expansion. Look at the inspiratory pressure and the exhaled tidal volume, or the inspiratory pressure and the minute ventilation. And then, after you've ruled that, because that's the life-threatening one if you have a tension pneumothorax, then let's look at everything else. First, rule out for tension pneumothorax. Okay, you understood me? Delivering the breath into the lung is actually moving across an open pathway into the pleura. And now you have an intrathorax pressure that's compressing the lung and not escaping. That's what a tension pneumothorax is. High peak inspiratory pressure, low exhale tidal volume. Heart rate typically goes down, blood pressure drops, SATs are dropping, and your patient's going to die. But not now, because you know what to do. You know what to do now, because the tension pneumothorax has to be released. But what's going to happen right now is small breaths with an ambu bag until help comes. And this is, by the way, an emergency. Okay, low inspiratory pressure alarm. Guess what? Low inspiratory pressure occurs, low exhale tidal volume, low minute ventilation, low inspiratory pressure, you're disconnected. Or the cuff has ruptured and now you've got a huge leak. You come into the room and you're hearing this oof, 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 with every breath because the air is leaking around the cuff. That's a cuff leak, okay? But you also might be breathing the bed, not the patient, because the patient became disconnected, okay? Same kind of thing that happens when we see a low PEEP or CPAP alarm. It's a baseline alarm. You've had some kind of disconnection or an obstruction. The circuit is disconnected with low. Obstruction, of course, is high. If the patient has auto PEEP, it's going to be a high alarm. So those alarms go off saying, too much gas trapping in the lung, help, 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 help. Obstruction in the circuit, help, 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 help. Or disconnected, help me, I'm going to die. The low PEEP alarm is a circuit disconnect alarm. Now, I think last but certainly not least is the apnea alarm. That's set with a 5 to 10 second time delay, and what this actually does in our ventilators, not all, but in our ventilators, if you have a 15 to 20 second time delay, let's say you're on pressure support ventilation, no mandatory breath, but you've gone 15 to 20 seconds without a breath, the vent is going to turn on in a mode called apnea ventilation. So it'll turn on in that mode because the patient's not breathing, the vent will start breathing for him. Okay? And then there's high and low FiO2, and that's all related to whether or not the mix of gas actually is achieving your FiO2. So excuse me for a second while I cough. Thank you. I don't need to be intubated, but my producer, director, and videographer had a coughing spell. And he's doing a great job because he's coughing into his elbow. Yay! All right. Very good. So patient issues. Low volume, low pressure, low respiratory rate apnea, high pressure, high respiratory rate, minute ventilation. Mechanical issues, low oxygen, and actual circuit disconnect and mechanical failure. All really important for us to differentiate. And by the way, the most common alarm, high pressure. Most common. And it is a signal to tell you something is wrong. It's not merely meant to be silenced. It's a signal that something is wrong. So pay attention to that signal. Okay. Always respond to all alarms as quickly as possible and determine the nature of the alarm. Start at the patient. Are they synchronous? Are they connected? Is there secretion? Can I hear gas movement? Can I see gas movement? What is the heart rate? What's the blood pressure? What's the SAT? And then work backwards. Work backwards towards the machine. Manually take the patient off the ventilator if you can't discover the problem, but it's persistent. If the patient is in distress, off the ventilator and bag, and do that quickly. Or if there's a mechanical problem, your vents failed. Okay. Now, in the time of COVID, this is difficult because taking your patient off the ventilator means you're going to aerosolize gas. You now have opened a closed circuit. So you should discuss with your providers, probably on a daily basis, if there's an issue where I have to disconnect from the ventilator, what do you want me to do? And make sure that you understand that that does put you at risk for aerosolization. So remember, you never, ever, ever, never, 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 never go in that room without being fully garbed. And just because they're on a ventilator doesn't mean you're safe, because if there's a pop-off or you have to disconnect them to save their life, you are now protected if you're in PPE, but if you're in there without PPE, you are not protected. And that is incredibly and profoundly important. And just remember, aerosolization of droplets of the moisturized gas, aerosolization can stay in the atmosphere in that room for an hour to 2 to 4 hours. So we always want to be aware of that. So even if you think, I'm just going in to shut off the pump, or I'm going to do this, I'm not really even going to touch the patient, it doesn't matter. You went in that room where you had aerosolization. So always be careful. Okay. When in doubt, when you can't figure it out and the patient isn't breathing and his heart rate is changing and his blood pressure is changing and his SAT is dropping, disconnect from the ventilator bag and call RT on 911. Help, help, help. This is not a question. This is an emergency. I can't maintain the ventilator on my patient. I am now bagging them. I need help. 911. 911 RT. So finally, I just want to talk a little bit about ventilator liberation. Liberating patients from ventilator is really, really important. So we do 4 basic steps. We first evaluate, are you medically ready? Are your lungs ready? Are you able to breathe? And are you ready to extubate? So there's multiple things that we evaluate. This is really in concert, of course, with your respiratory therapist and your physician or provider colleagues. They are evaluating using a beautiful ventilator pathway order set for ventilator liberation. We want to get you off that ventilator as soon as safely possible. So we're going to look at your illness. You can't have a fever. You shouldn't really be on much vasopressor. You can be on a very low level, maybe 4 of norepinephrine, and you should be able to have a reduction in your sedation, and you're able to maintain a mean arterial pressure of less than 60. You're medically ready, right? And no fever, because if you have a fever, you're going to breathe fast. So no fever. Now we look and see, are your lungs ready? Do you have an FiO2 less than 50% with a P to F that's greater than 200? Is your PEEP on 8 or less? Is your respiratory rate less than 35 times a minute? Is your minute ventilation 15 liters a minute or less? Is your tidal volume greater than 5 cc's per kilogram of ideal body weight or predicted body weight? Because that means I've opened your lung. Now I'm going to titrate your sedation down to off and give you a spontaneous breathing trial. So we talk about sedation down to off as a sedation holiday, and then we look at a spontaneous breathing trial, and it's a 30-minute default. The RT is really going to assess success or failure by looking at your respiratory rate, your blood pressure, your desaturation, and are you feeling comfortable or uncomfortable, and a frequency divided by tidal volume proportional ratio that's greater than 105. That's actually a vent readiness test. Okay, so now we're going to release your cuff. We're going to suction you, release your cuff, evaluate your level of consciousness. Can you manage your secretions, etc.? And then we're going to pull your tube. So we have a whole protocol for ventilator liberation. Patient must be medically ready. He must be lung ready. He must be able to tolerate a reduction in sedation, maintain his ventilatory strategies, and then he's ready to extubate. So in general, these steps, medically ready, lung ready, reducing sedation, SBT, ready to extubate, happen sequentially and rather quickly. We don't try for 4 hours. We don't do it in the middle of the night and put the patient back on the ventilator on all his high-level settings. We like to do that in the morning when the physicians are available to actually communicate with respiratory therapy so that therapists can extubate as soon as patients prove they're worthy. The sooner you're off the ventilator, the better off you're going to be if you're successful. And we certainly know that length of stay on ventilation correlates to the process of delirium, to muscular atrophy, to diaphragmatic atrophy, and to a reduction in long-term outcome. So this is something we want to push every day. And we do actually do evaluative testing. As soon as you prove you're medically ready, we start evaluative testing about liberating you, freeing you from that ventilator, because that's the first step in freeing you from the intensive care. And by the way, just don't forget, it really is, it's really a difficult place to be. Thank you so very much. I hope you've enjoyed this segment of Basics of Invasive Ventilation, Category 3. And you may need to go back and review 1 and 2 because now you have a whole picture that can help you to understand mechanical ventilation, do's, don'ts, whys, and wherefores, and what we're trying to do when we intubate patients and ventilate them artificially. What are our goals? Can we meet them? Can we oxygenate and ventilate in the meantime? Always, always, always protecting your lung, protecting your lung. Thank you so much. See you soon. Ta-ta for now.